right, so good morning, guys. I'm Gabby, one of the chiefs. So I'm going to be talking about LVADs this morning, specifically how to assess a patient one, how to troubleshoot the device, and differentials to include for hypotension in these patients. We don't see them here really, so this is for future reference. So patients that have ventricular assist devices or VADs are super sick. They're class 4 for the New York Heart Association, like functional classification. They have ES less than 25%, or they have heart failure that's been resistant to medical therapy. For these patients, VADs can serve for a couple purposes. They can be a bridge to cardiac transplant. They need something called destination therapy for patients who aren't transplant candidates, or they can be a bridge to recovery, so like implanted temporarily. They give the patient's native heart function a chance to recover. VADs vary from each other in a couple ways. There are different manufacturers. They can be biventricular or connected to only the LV or RV, with LVAD being the most common device. They can be located outside or inside the body. They can generate either pulsatile or continuous blood flow, although the pulsatile pumps have fallen out of style. And they differ in how they create blood flow. So they're axial and centrifugal flow devices. They can be temporary or permanent depending on the patient's needs. For patients that have a little bit less hope of recovery, they make it a total artificial heart. Obviously, for title selection, we're going to focus on LVADs. So this is a schematic showing the entire LVAD setup over on the left, and accessories associated with it, and the anatomy of the pump on the right. So LVADs pull blood out of the apex of the LV into an inflow cannula or tube, and then into a pump. The pump then shoots blood into either the ascending or descending aorta via an outflow cannula. There are 2 rechargeable batteries that serve an external power source. And there's a controller or a system driver that monitors pump function, so parameters like flow, speed, and power, controls pump speed, manages power supply, records data, displays alarms and info about battery life and function, and you can download data from it for analysis. It also contains a backup battery. And there's a drive line that's a bundle of wires that provides power to the pump and sends operating details from the pump back to the controller. It has an external and internal part that's tunneled subcutaneously from the epigastrium to the pump. On the right is an example of a centrifugal flow pump. There's this impeller or rotor that's magnetically levitated and spins, basically throwing blood forward. So there's some basic terms you should be aware of. So revolutions per minute, RPMs or speed, that determines pump flow. This is a parameter set by the patient's heart failure doctor, and it's modified as the patient's flow needs change. There's flow, which is in units of liter per minute. It's essentially cardiac output. It's calculated from a number of things like power, RPMs, patient's somatic rate, and blood viscosity. And it's also determined by the difference in pressure across the pump. So if you increase pump speed, you increase flow. If you increase the pressure gradient, you decrease flow. Then there's pump power, which is the amount of power required by the device in watts, and it varies directly with pump speed and flow. Then there's something called pulsatility index. It's the magnitude of flow pulse through the pump. And it's usually valued as measured over like a short time interval, like in seconds. It fluctuates based on the patient's volume status and the heart's contractility. And in general, it can be thought of as a contribution of the patient's heart. So higher values indicate higher pulsatility. That is, the pump is providing less support to the LV. Native heart is providing more support. The opposite is true for lower values, which indicate lower pulsatility. The pump is providing more support, and the patient's heart is providing less. This is something monitored routinely because a significant drop indicates a decrease in blood volume, and a very high value indicates more activity from the patient's heart, and some adjustments need to be made. There's suction events, which is something that happens with flow volume or flow status. That can be intermittent, continuous, or self-resolving. When there's reduced preload, this increases negative pressure in the LV, and part of the ventricular wall is actually sucked over and covers the inlet cannula, causing a low flow alarm. This can also happen if the inflow cannula actually migrates into the wrong position. Some pumps have an automatic function to where it quickly decreases the speed to relieve these events, which is important because they can trigger ventricular arrhythmias by irritating the myocardium. Then there's modes. Just know that there are fixed and automatic in regards to speed, with fixed being more static and automatic being more dynamic. Okay, all right, so here's your patient. There's some things you should be aware of when assessing this patient versus others. They may not have a palpable pulse, so you may not get an accurate pulse ox reading or blood pressure with the cuff. So you want a Doppler, the map with the ultrasound probe. Their MAP goal is like 60 or 70 to 80. So the A-line is like a really great idea for continuous MAP monitoring if they're like really sick. When listening to their heart, you want to hear a high-pitched word sound to confirm the device is actually on and functioning. Echoing these patients is super helpful. You can see the sizes of the RV and LV and the positions of the cannulas can help guide your assessment. Slap some color Doppler on the valves and the cannulas to see if there's rigor or inflow. Patients are preload dependent and afterload sensitive. So low preload and high afterload states will really alter their perfusion. The device can be interrogated just like a pacemaker or ICD. EKGs aren't significantly affected by the presence of the device, so BFib, BTAC, first thoughts are still recognizable. EKG is actually really important to get because they may tolerate otherwise lethal dysrhythmias because most of their cardiac output is dependent on the device. Epinephrine and cardioversion are safe. They're on chronic anticoagulation. They'll usually be carrying a bag with them containing a battery charger, replacement wires, backup controller, all for their device. These patients have an LVAD team coordinator with whom we should always discuss their care. The patients have this person's phone number. If things become dire and ACLS has been initiated, it's still kind of up in the air, but some people recommend no chest compressions unless you're very sure they're not refusing. There may be a risk of dislodging the device or the cannulas, which sit right below the sternum. Most patients have a color-coded tag on the controller specifying what device they have, what institution put it in, and a number to call. So this is a controller for the HeartMate 3 device. It's very similar to the HeartMate 2 device, which is one of the more popular devices. The pump functioning symbol should be bright green when the device is on. You can press the display button to see parameters that have been set, like speed, flow, PI, backup battery, charge status. The cable disconnect symbols will light up if the batteries or driveline become disconnected from the controller. These are the status symbols. Basically, the red heart means hazard, emergency, critical failure, do something now. And the yellow wrench is urgent. We have time to troubleshoot whatever is going on. Various alarms will pop up on the display screen for something wrong. There are many different types of alarm messages that can pop up, even some that are specific as like call LVAD contact faulty driveline. So we're going to hang out on the slide for a second to go over some of the normal LVAD parameters and what they mean. High power can signal obstruction like pump thrombosis, which occurs in about 8% of patients despite being on anticoagulation. It can occur randomly or when the device fails and has been off for too long. You might see sudden power spikes and overflow alarms. The controller will overheat and feel really hot to touch because there's like this increased energy requirement. The patient might be totally fine or show signs of peripheral emboli like a stroke, and they may present hypotensive acute heart failure because the device is failing. Diagnosis is best done for TEE, but a CTA can be helpful as well. When treat with IV heparin, if they're super unstable, they might need thrombolytics or emergency surgery to actually exchange the pump. You can place them on ECMO if necessary. If the device has been off for an unknown duration of time or even for like several minutes, don't turn it back on because potentially fatal emboli can be thrown everywhere. You can also get this high power alarm with increases in afterload, such as like severe hypertension. Low power. So the device failure can be due to something as simple as like the batteries aren't charged. So replace the batteries, switch to an alternative power source. The HeartMate 2 and 3's controller can actually plug into the wall if you have the AC adapter. Look at the circuit of connections. Something might be obviously damaged or unplugged. The patient's clinical picture and any other alarms on the device can help you assess what's going on. AP lateral X-rays can show any connection or placement abnormalities that might require surgery fix. If you need it, CT can show more like precise dislocations problems. So high pulsatility index. So PI increases when preload and contractility increase. So get this alarm with recovery of native LV function, so the patient's heart's getting better. So having with lead damage is going to cause pump function to go haywire. So you can check down RPMs, but reading support is probably something not going to be going wrong. So low pulsatility index, PI decreases with blood volume and afterload reduce. So the patient's native heart function might be worsening, like an acute MI. So you want to increase the pump speed and or give like low doses of WV or milrinone. Hypovolemia, so they might need fluids. Remember, these are heart failure patients, so don't go wild with fluids. Excess pump speed, so maybe the RPMs are turned up too high for the patient. It's emptying the heart way too fast. You want to turn RPMs down. High flow rate happens to anything that causes vasodilation like sepsis and anaphylaxis, which will work up and treat accordingly, and use vasopressors like Levoped if needed. Low flow rates, so bedside echo can be helpful in differentiating some other things here. So low flow alarm plus a small RV and LV, this is like hypovolemia. hemorrhagic shock, a dilated LV and RV, and no hum when you're listening to the heart. Suspect the pump's not functioning, like a thrombosis or obstruction. Small LV, dilated RV, suspect RV failure, pulmonary hypertension, PE, or a suction event cause the alarm. And arrhythmias and severe hypertension are other causes of low flow. Suction events, which we talked about earlier, you want to get fluids, turn down RPMs to allow the LV more time to fill, and treat whatever the underlying problem is. Okay, so things you need to keep in your differential for hypertension in these patients. First one's an acute MI. Might present as like new onset LV dysfunction, fluid overload, cold extremities, altered mental status, etc. MI can be caused by a plaque rupture, obviously paradoxical thromboembolism DVT, or thromboembolism from a thrombus that's just sitting in the LV or the aortic root. It can also happen when the device fails. These patients can undergo cardiac cath, angioplasty, and stenting if they need to. Acute decompensated heart failure. So recurrent or persistent heart failure is a combination of these patients, and some 20% actually end up in right heart failure after getting the LVAD put in. Use diuretics and nitrates cautiously because they are preload dependent. If nothing you're doing is working, they end up in like shock or arrest, you can try to bail it out with VA ECMO. Arrhythmias are very common, especially in the first 30 days after getting the LVAD put in. And they're already at increased risk because they have ischemic heart disease or other types of cardiomyopathy. So run through the ACLS protocol if you need to, placing the pads away from the LVAD or the ICD if they're present. Defibrillate unstable patients, stable ones, even those in VTAC or VFib, can be medically managed. And a lot of these patients will also have ICDs at the same time. So if they're complaining of palpitations, shortness of breath, or like shocks, you definitely want to have the ICD interrogated. Cardiac arrest. So it can be difficult to determine if the patient is truly arrested due to lack of standard measurable blood pressure and pulse. So evaluate for signs of perfusion, end-tidal CO2, mental status. I previously mentioned that there's no consensus on compressions versus no compressions, but the American Heart Association in 2017 said they suggest you do compressions if end-tidal is less than 20 after intubation and the patient shows signs of non-perfusion. So aortic valve degeneration occurs in like 90% of patients using these devices over an extended period of time with a varying time course to onset. It happens because of increased mechanical stress on the valve and artificial blood flow, which eventually leads to regurg. Pericardial tamponade, so it happens as a result of dissection or trauma. Spontaneous bleeding into the sac is rare, but can occur if they're post-op. Don't do a pericardiocentesis on them unless it's very clearly tamponade because of the risk of device complications. So anemia can happen either from hemolysis or hemorrhage. With hemolysis, it occurs with 80% incidence. These patients are at risk for it because they have increased shear stress on their red blood cells with the device. Clinically significant hemolysis, like jaundice, elevated LDH, and these patients have an elevated LDH at baseline, but if it's like 2.5 above their normal, it's usually a result of thrombosis. There can also be secondary dehydration, stenotic or regurgitated or prosthetic valves. They'll present worsening heart failure in addition to anemia. There's nothing really simple to do about this except transfuse if they're unstable. They may actually require a device exchange. And you obviously have to calculate if you think a clot is there. The incidence of hemorrhage is high in these patients, especially in the GI tract. They're on lifelong anticoagulation. They also have an acquired von Willebrand factor deficiency that contributes to bleeding risk. The shear stress from the continuous flow of the device is thought to alter the von Willebrand factor multimers, so they're more prone to cleavage by the ADAM CS13 enzyme, and so they don't bind platelets as well. They're prone to post-op bleeding, intracranial hemorrhage, their risk for GI angiodysphagia, and AVM is induced by altered GI perfusion from non-pulsatile blood flow. Reversing coagulation is like a touchy subject, I guess, for these patients. They're chronically hypercoagulable, so full reversal kind of puts them at risk for device thrombosis or thromboembolism while they're like sitting in ED, which can be fatal. Some recommend getting platelets, vitamin K, or desmopressin. Definitely talk to the LVAD team before reversal the first time. So infection, sepsis, infection is the most common complication, with driveline infections being the most common. You can also have infective endocarditis, myasthenitis, pump or canal infections, and pump pocket infections, like in this picture, an infection of the space where the pump sits. They require drainage and debridement, device removal, or some patients can actually be considered for chronic antibiotic therapy. Some drive lines cross the diaphragm, so that risks abdominal bacteria infecting the device. Do the whole sepsis workup and treat with broad spectrum antibiotics. So trauma. So the cables can be damaged, cannulus pump could be like physically dislodged, and then you want a percutaneous trauma. Treat and stabilizing traumatic injuries. You definitely need CT surgery on board ASAP for any suspected device applications. And then stroke. So ischemic is more common than hemorrhagic. They're more at risk for both than patients without LVADs. Don't push thrombolytics or reverse anticoagulation without consulting the LVAD team. There's just not a lot of strong evidence for doing these things in these patients, and LVAD centers often have their own approach to this management. Hypotension associated with stroke is like super rare, but whether it's a cause or consequence of the stroke, patients are more likely to have increased risk in hospital mortality and complications. Just remember, no matter what's going on, stabilization and transfer to an LVAD center ASAP are the top priorities for managing these patients. These are my references. Does anybody have any questions or comments? Oh my God, yes.
Okay.
Dr. Grunschreiber.
I'm glad you presented this. We don't see much of this, because I've seen a few at UHB. There were 3 questions on last year's in-training exam on this, so definitely I would look it over. Coach has several questions on this. One was on the treatment of ETAC, which you assess and treat just like you would in anyone without the LVAD, as you mentioned already. One was on infection, which you mentioned, and you want to cover them well, especially with things like vancomycin to cover staph. And one had to do with the different components and if they fail. When I learned the cases I have, they always will have someone you can call 24/7. And so you should find out where they had it, where they had it done, and call them. They're very good about it. And if the patient is transferable, if they're going to survive a transfer, almost always they'll take them. And I transferred one up to Columbia Presbyterian with it.
Okay. All right. Any other questions or comments?